Welcome to the latest installment of the AJT Journal Club series. Today's Journal Club, an investigation of outcomes with the new 2018 donor heart allocation system in the United States, is hosted by the AST Thoracic and Critical Care Community of Practice. In a moment, I will turn the discussion over to our moderator, Dr. Shelley Hall from the Baylor University Medical Center in Dallas, Texas, who will introduce our presenter, Dr. Mandeep Mehra from Brigham and Women's Hospital in Boston, Massachusetts. But first, we have a few housekeeping notes to help you engage with today's discussion. In a moment, my apologies. There is currently a viewership polling question displayed for the audience. Please take a moment to answer this question while we finish the remaining announcements. Please note that your lines have all been muted so that only the presenters can be heard for the recording. If you have a question during the Journal Club, please use the Questions tab in the GoToWebinar panel. You can find this tab near the bottom of your panel. If there are any questions that we do not have time for, we will either answer them individually offline, or we will post the full question with the answer to the website following the Journal Club. Please be aware that if you click the X icon in the upper right of the GoToWebinar panel, you will close and exit the webinar. This Journal Club is being recorded, and the archive will be available within 24 to 48 hours. Finally, when you log off at the conclusion of today's Journal Club, you will see a short survey to complete. We will use this information to help keep our content current and engaging. I will now turn the session over to Dr. Hall to begin our presentation.
Thank you, Brian. I want to thank everybody who's taking time out of their day to listen. We hold the wonderful title of being the largest registration for a thoracic webinar so far to date with AST, so we're very excited about that. And that tells me that you're all engaged, either happy or not, about the current allocation system. And Dr. Mehra needs no introduction in the world of advanced heart failure, but he's going to kick us off utilizing the Cogswell et al. Paper on having a good discussion about the new allocation system and the impact it's having. Mandeep?
Thank you so much, Dr. Hall. It's such a pleasure to be here, and I'm deeply appreciative and very, very excited to see how much enthusiasm is being expressed by our colleagues who have really signed on to this webinar in great numbers. So our Journal Club today is entitled An Early Investigation of Outcomes with the New 2018 Donor Heart Allocation System in the U.S., and this was the title of the manuscript that we'll discuss in some great detail. But as I go through the didactic portion of this conversation, I would really like to frame this issue in a much, much more clearer way so that we can generate a reasonable amount of discussion, debate, controversy, and I dare say provocation. Now, my disclosures are at the bottom of this particular title slide, as if Brian will advance that, my disclosures should be seen there, but if they aren't, I will tell you that I do serve as a consultant for a number of companies, including Abbott, Medtronic, Portola, Bayer, and the BAME Institute for Clinical Research, as well as Leviticus, New Pulse, and Fine Heart. Now, what's the background? And I'd like to go over some key points with you. Until this recent allocation system was created, 2005 had marked the last change in the priority listing urgency for heart transplantation in the U.S., and it went into effect sometime in early 2006. Now, what was unique about that last system was it was a fairly simple system, and it basically categorized people and candidates into urgent or ambulatory status. And the urgent status was divided into two very clear groups, 1A or 1B, or ambulatory was 2. Now, the problem with the urgent category was that it included a very wide spread of phenotypes. The same priority, for example, was given to a patient on ECMO or BIVADS or stable patients on 2 inotropic agents at low doses with a PA catheter in place. And this, of course, was far too simplistic with the type of severity of disease we see. Now, the second interesting issue was that there was no viable pathway for non-inotropic therapy treatable patients, such as those with congenital heart disease in many cases, or those with restrictive cardiomyopathy or amyloidosis or hypertrophic cardiomyopathy. So quite clearly, there was a challenge in this system in the old way. Now, let me give you a glimpse into one of the most important problems that occurred with the old allocation system, and we'll focus our attention on urgent 1A listing candidates. The 1A listing candidates, or those, if I may say, the soup of people who ranged anywhere from ECMO-bound patients to BIVAD-bound patients to mechanical circulatory support patients with complications to just people sitting in the ICU or on a floor with inotropic therapy and a PA catheter in place. The problem was that it created a huge degree of regional heterogeneity. Shown on this slide is a very incisive figure that was drawn out from an editorial written by Lynn Stevenson quite some while ago in the Journal of Heart and Lung Transplant, where it was very clear that if you look at Region 5, which is on the West Coast, the number of patients listed at a 1A urgency that could get transplanted within, say, 30 days was quite significant. Almost 35 to 40% of them would get transplanted. On the other hand, if you looked at Region 1, which is where I practice in Massachusetts, the number of days that it took to transplant a status 1A patient in the old system could sometimes go as long as more than 3 years. Can you imagine that? That a high urgency transplant was waiting for more than 3 years to be transplanted. So clearly this system was somewhat diseased in the way in which it distributed organs in the United States. Now, the new system that was created and launched after a lot of deliberation and very thoughtful engagement by the membership group that devised it, with great comments from the public, and many of you perhaps even commented on it, is shown here. Now, this particular slide shows the old system of the 1A, 1B, and 2 on the left, and it shows the new system, which includes 6 statuses on the right. And what this essentially encapsulates is that now the 1A system is pretty much divided into 3 hierarchical statuses of 1, 2, and 3 in a simplistic way of looking at it, so that you have VA ECMO patients who are clearly number 1 in status and at the highest priority. And you have 2 who are basically patients who could be on an intra-aortic balloon pump or have a mechanical circulatory device with malfunction, or could be in sustained VT or VF. And 3s are the traditional patients with continuous infusion of single or multiple IV inotropic therapy. So in a way, this system now broke down the 1A into these 3 groups, giving hierarchical priority to those groups of patients who we think were not necessarily equivalent. The other key point of this particular allocation system is encapsulated in 4 key principles. And why was this necessary? The first key principle was that this system was designed to reduce waiting list mortality. Second was to reduce exceptions for those who were disadvantaged by the previous system. So take the congenitals or the hypertrophs or restrictives. And in fact, in this new system, they have a status priority of 4. The third was a coherence of physiologic status to determine and discriminate severity. And finally, it was really the hope of the group to enhance access by modifying geographic distribution and not see this incredible regional heterogeneity as was noted with the prior system throughout the U.S. So how did we consider this particular analysis? Here, I would like to give you the key methodology of the analysis that we will discuss in some detail. So we first looked at 3 years prior to the new system launch. So that would be October 18th, 2015 to 2018, and compared it to the very early experience in October 18, 2018, out to just a very short period of March 31st, 2019. So these were people listed and transplanted around this time, with outcomes that were available to us through the end of June 2019. Now, the principal endpoint that we examined was post-transplant survival, which was free of retransplantation. Naturally, retransplantation is not very commonly done early, but if someone does have a significant primary graft failure, there are cases where the allograft is retransplanted, and in those cases, we wanted to be sure that we captured that as well if there was a significant swing in that area. We created Cox models for adjustment, and we created several competing risk models, including sensitivity analyses, but we also looked at net outcomes. The net outcomes meaning what was the improvement, if any, to the waitlist survival, and was there a counterbalancing of that with decreased post-transplant survival or maintained post-transplant survival? So this was really the main questions we asked. And I will encapsulate for you the three main findings. And note that I have underlined the word early. These are extremely early findings, and as we discuss this in some detail, you'll understand why we chose to move quickly to enter these findings into the scientific lexicon and the literature. The three main findings that we noticed were the following. The first was that the epidemiology of the candidate and transplant process has changed very uniquely, materially, and significantly since October 18th, 2018, and was a date that disrupted the allocation system. The second is that the waitlist survival has improved significantly, which was the primary intent by those who created the system. And third, the post-transplant survival, at least in the early experience, appears to have decreased. And there are many ways to look at this information, as we will do in the subsequent slides. Now, first things first, let's look at how materially the characteristics of patients listed and transplanted in the prior versus the new system have changed. So if you look at some key findings, let's first look at those patients who were reaching the point of transplantation with a left ventricular assist device in place. And in the old system, about 40% of patients were bridged to transplant with a durable mechanical circulatory support device. And that we noticed had halved in this particular new system. The second thing that we noticed is that this was counterbalanced by an increase in temporary mechanical support, be it with a intra-aortic balloon pump or with a Impella pump or a tandem heart, and that there was a nearly fourfold increase in that particular transition point. And then when we looked, interestingly, at ECMO, which most of us are afraid would not give us good outcomes post-transplant, ECMO at the time of listing was still a low-frequency event. So it was really only about 6.5% of these early candidates, but it represented a fourfold increase in the use of ECMO in these patients, suggesting that somehow that behavioral economics was already in significant play with the new allocation system, that as soon as a new allocation system came, there was a significant difference. A few other key points. When you look at the recipient hemodynamics, well, the key point is that these differences are not striking, but in the new system, under the new system, these patients, the recipients, the candidates, appeared to be a bit sicker. So they had much higher pulmonary vascular resistance, their wedge pressures were a bit higher, and their cardiac outputs were lower. Now, you look at these average numbers, they appear significant, but they do not appear to be dramatically different in terms of the means. But you can imagine that when you're comparing two means, that there are significant outliers in either direction that determine some of those changes. Now, another key important point is outlined in the donor characteristics that have been observed. And for example, the ischemic time has shifted significantly and has increased significantly in the new allocation system. And it may just be that this increase in the ischemic time means that we are bringing donors from slightly more greater distances. And when you look at that, that means that we may actually be flying instead of driving, and we may actually be taking jets instead of helicopters when we actually move in that direction. So you can imagine that there are, in fact, infrastructural challenges that are imposed by a simple number that you see in terms of a change in ischemic time. The donor age seems to be going up by a very, very small fraction, again suggesting that we may be taking greater chances in terms of accepting donors that are slightly older. There was no difference in whether we match a female to a male in this particular data. But what is strikingly achieved in a positive way is that we now have a much, much more shortened waitlist time. That is, from the date of listing to the date of transplantation, there is a dramatic decrease between these two particular eras. So you can see that there has been a very significant disruption, and we will now go into discussing some of the outcomes that we've observed in this early analysis. Now, when we look at the first survival analysis, which is freedom from death or retransplantation, in the prior system compared to the new system, one thing that you immediately see in a striking way is that you don't see any difference in the first, say, 6 weeks or so of survival, but later on the survival appears to start to drop at around the 3-month time point out to about the 6-month time point. And when you ask the question, which component of the status is contributing to this, it turns out that if you nest the analysis simply in the urgent category of 1A in the prior system versus the new system status 1, 2, and 3, you find that most of the contribution is in this group, particularly because 83% of all of the transplants that were observed in the first early phase of the new allocation system appeared to be in the category of status 1, 2, or 3 in the new allocation system. Now, I will caution you, actually, if you go back to that slide, I will caution you that you must interpret this sort of a survival analysis with trepidation. This should not be assumed to mean that this is an absolute. This represents a very early look. You can see that as you go out to the later time points, the number of patients at risk available for adjudication in the new system decrease dramatically. As a result of which, I think there are certain biases that one can, in fact, admit to in this, and the confidence intervals towards the later time frames are so wide that one cannot be reasonably reassured that this is, in fact, what will be observed when the numbers triple, quadruple, or pentuple in the new system. So I would just caution you that this is just a very, very early yardstick that we have encountered and shown. And then we'll go on to discuss the next part of this, which is the important concept of a net impact. Now, we actually created this modeling in this analysis where we thought, let's ask this question, did we save lives on the net waiting list? And it turns out that the new system, by virtue of achieving transplantation in a much shorter period of time, does in fact save potential lives on the wait list both over the 3-month or the 6-month period. This is again modeling that that should simply give you a directional emphasis rather than absolute emphasis. So it seems that yes, the new allocation system, if one were to say, did it tend to reduce the waitlist time and the waitlist mortality? I think the answer would be yes. Now, if you then ask the second question in the next slide, which is the post-transplant mortality that was observed, and of course, this is assuming the worst-case scenario, so one has to be very cautious looking at this. It seems that the potential increase in post-transplant mortality that could occur with this system may be 10 times greater in numerical order than the value of the lives saved on the waiting list. And whether this 1 in 10 ratio is something that is going to withstand time, will it come to 1 to 1? Will it change to 1 to 2? Will it be 1 to 3? That remains to be seen. But I think that as we interpret this data, it appears that the direction of the numerical changes that we are seeing in this disruption appear to be a clear improvement in the waitlist mortality and perhaps some worsening, and we just simply don't know how much absolute worsening there is. This model, of course, suggests the worst case scenario. Now, moving to the next area, let's go over the purpose of why we published this data this early. Because some would say, "Oh, come on, was it too early to publish something like this?" Sure, but why we did this is because we wanted to simply develop a healthy debate on this issue. And the fact that we have engaged in this webinar journal club today is an example of us having achieved that issue. Now, the principal reason why we went about this is that most of us observed a significant practice change. We required great pivoting in 4 areas within our own clinical programs. First, we began to see a marked increase in resource use in the ICUs and in the cardiothoracic surgery units, where people would be sitting on ECMOs or BiVAD support, temporary central mags, impeller pumps, etc. And we wanted to understand what it means. We were seeing a changing cost of care at many programs, including ours here in Boston. We were concerned about increasing morbidity, and we were concerned about the quality stress that it imposes on patients as well as on their care providers. How long are they staying in the hospital? What does this mean? What is their rehabilitation potential? And then we were very, very concerned about this possible mortality increase in the new system that we wanted to bring to a purposeful debate with the community. There are other issues, and I want to point out some clear critiques that are very valid for this analysis, and we accept them. First, critique is, "Oh, come on, this is far too early to look at this," and that this is an insufficient time comparison. Yep, we agree with that. But again, as I pointed out to you, our idea was really not the absolute accuracy of this, but to create the debate that will allow us to pivot towards a better improvement in patient outcomes. Why? Having practiced in the field of heart transplantation now for 3 decades, what I have learned is that you do not necessarily need randomized controlled trials in heart transplantation to change outcomes. What you need is a well-constructed policy. You need well-constructed best practices and thoughtful, experienced clinicians managing patients. And it turns out that we know in heart transplantation medicine and surgery how to pivot whenever a regulatory or a clinical stress is placed on our programs. And the idea was that the sooner we begin to embrace this, and the sooner we go into this with our eyes wide open, that we would probably be able to have a better outcome and pivot into a improved outcome scenario quickly over time. The second critique that is quite valid is that this model is only valid for the first few months, and And one of the critiques that has been stated is not just that we didn't have enough patients to take out to the 6-month time point, but that there is evidence of non-informative censoring bias in this data, which is a very valid argument that that you tend to estimate bad outcomes. If there's a bit of an early bad outcome, you tend to assign the same bad outcomes when you have non-informative censoring bias in a actuarial or Kaplan-Meier plot. So this is well taken, which means that hopefully the subsequent data will start to show some narrowing. And then the other critique is, look, our field knows how to course correct, and it will. And this was basically the meaning is that well, look, you were looking at a very mature time point in the old system, which is the last 3 years of the old system, versus a very immature time point in the new allocation system. So you're really comparing apples to oranges, and for that I would say, yeah, maybe it's quite possible. So these are some of the key critiques, and I'm sure Dr. Hall and many of you may be able to counter others, but our hope is very, very clear. Our hope in providing this data to you is that we believe that the post-transplant mortality will course correct and will be much less in reducing, and will reduce this whole winner or loser center mentality that may occur as a result of this particular disruption, because some centers that do very few transplants may become losers in this if they have one bad outcome, and other centers could reside as winners in this. And perhaps we need to ensure that this winner or loser mentality doesn't actually overtake the idea of this new allocation system. And then our other thought and hope is that the community will re-engage in deliberations on two key aspects. The old system was prone to some gaming. If we are honest with each other, we would admit that there was such a thing. We were not gaming it for a malicious reason, but many centers would try to do the best they could for their patients to try to get them to a transplant the quickest. And in that, it created perverse incentives in some cases. So there is an opportunity for gaming at the very top of this list. So let's say with the use of intra-aortic balloon counterpulsation, this should be debated. Or B, should we accept this marked decline in durable LVAD implants? Is it appropriate to say now that that there is a halving in bridge to transplant durable LVAD implants in the U.S.? Is that serving the field and patients appropriately, especially when we have a new, much more forgiving left ventricular assist device implant? So I hope that some of these issues will be openly discussed and debated in our community, and perhaps we would come to a realization of the appropriate best practice in this regard. And finally, I would be extremely remiss if I did not provide the appropriate casting credits. I simply present this data as a presenter and participant to a enormously prolific group that put this study together. I want to credit Rebecca Cogswell from the University of Minnesota, who really worked exceptionally hard to curate this data and bring it to the forefront in a timely fashion. And the other members of our group, Dr. Ranjit John from Minnesota, Jerry Estep from Cleveland Clinic, Sue Duval, who is the statistician and who helped us enormously try and understand what the caveats of this analysis are, Ryan Tedford from Charleston, Dr. Frank Pagani from University of Michigan, Cindy Martin from Minnesota, and of course, I played a very small role in also helping put this together. So I thank you for allowing me to present this this paper to you in the form of a journal club, and I will now turn this back to Dr. Hall or our administrative colleagues to take the ball back from me and engage in a discussion.
Thank you, Dr. Mehra. That was an excellent review and setting the stage. I think all of the participants right now are wishing they weren't on mute because I'm sure all the hands are raised and there's all kinds of opinions out there. We encourage you to submit questions. Brian, you may just explain to them again how to do that.
Certainly, Dr. Hall. Please use the Questions tab in your GoToWebinar control panel to submit your questions. They will be available to Dr. Hall to vet during the presentation. Thank you.
Thanks. While waiting for questions, I do have some mainly to help Dr. Mehra and I maybe kind of go back and forth and try and figure out how do we create the best policy and how do we move forward. Dr. Mehra, my first question is that historically OPTN policy is focused completely on donor management and then wait list mortality, and has not historically utilized post-transplant survival criteria in the modeling. Do you feel like that is appropriate or should be changed?
Thank you for that question, and I've heard that statement made several times, and I actually, Dr. Hall, would consider that is partial thinking. I think that it makes no sense whatsoever to simply focus on the donor side and the waitlist mortality and leave post-transplant outcomes because if you think about the ethics of heart transplantation, the ethics of heart transplantation definitely include the greatest benefit for the greatest group of people, and you cannot do that unless the resource is looked at both from the supply and the demand side, and you cannot just look at it from a single economic fulcrum.
Thank you. I absolutely agree with you on that. I think one of the challenges with statisticians is they say they can't truly predict that. They can predict the post-transplant outcomes if we all behaved the way we were behaving in the prior system. But as you pointed out so clearly, we don't behave the way we behaved in a prior system. We change our behavior in response to the new system. And I think that's where they express their challenges over that. Question coming in from Amit Badier, and I apologize if I mispronounce names here. It is not one of my strengths. Will reduction in LVAD use force device companies to roll out more updated devices faster? For example, wirelessly charging bands.
What a great question by our colleague here. I actually think that this is a question that has several opportunities embedded in its answer. The first of which is that let's say it's granted that that at least in the short term we are seeing a decline in bridge to transplant rates with the new allocation system. Does this mean that we do not have a population of patients where durable LVAD therapy with its current excellent forgiving clinical profiles is being fully used? The answer is no. I think that there is a huge gap in the U.S. and worldwide on the use of left ventricular assist devices for a variety of reasons in patients who are not transplant eligible. So that these devices, while they were created for the transplant eligible patient, really their strength and their utility may very well be in the patients who are not transplant eligible, number one, or in patients who are not yet at the point where they're in extremis, but could in fact even be recoverable. Now, if that is the case, I would answer your question in two ways. First, we clearly need better devices that are fully internalized with wireless power sources. Why? Because that's fundamentally important for the quality of life of patients. On the other hand, if we are to expand the pie of use to 10x, tenfold, and put these devices in earlier and earlier with reasonable outcomes, then we do need such a device. On the other hand, I think that if we are honest with each other, we would realize that we are not considering the appropriate patient for placement of LVADs even today with its current technology, not just the bridge to transplant patient, but predominantly the lifelong therapy patient who cannot have the opportunity for a transplant. And I don't know, Shelley, if you have other thoughts, but you are a world expert in this area as well, and I would love to hear your thoughts.
I totally agree with you. I think that we continue to expect more and more from our VADs, and we want it quicker, faster, better, and that extends to our patient population as well. And transplant continues to be considered the superior option to VAD. And so if there's a way to get transplant faster than the VAD, there's this psychological and some data-driven that while short-term may be getting closer and closer, long-term is still questionable. So until we truly have devices that are the same long-term survival as transplant, there's going to be an innate push to move towards transplant and avoid LVADs.
Yeah.
Next question from Christine Sumby. What does the data on OPTN post-transplant mortality show?
So, say that again. I didn't quite get that question.
Yeah. What does the data on OPTN post-transplant mortality show?
Oh, and I mean, I guess, Shelley, you would probably know the most recent data in that regard. But I think what we have shown in this early look is exactly that, that there is, under the new allocation system, one can debate how much numerical reduction there is. Is it definitely statistically significant or not? But I think we're all seeing a challenge to the post-transplant survival, and all of it within the first 6 months.
Yeah, I think that as you continue to emphasize appropriately the early data, I think that I always say that now the world became New York, or the country became New York in learning how to manage ICU patients continuously. And there was a learning curve to that. And I absolutely think there was probably an early hit. And the big question is going to be, is that continued? The actual hard facts of the 1 year are going to be previewed to the Thoracic Committee later this month or early March, and we'll be hopefully able to share that data once it's cleaned out by the sub 6-month meeting in April. I think the biggest challenge is with the EUNOS data. If a patient dies, you have to enter that in 24 hours. If they're alive and you're just doing the regular updates, you have 90 days to enter the data. So that is why they have been very, very strict on a good 3 months plus after 1 year before they're going to start to analyze 1 year data.
Yeah, so I think that's well said, and I'll tell you, Shelley, in all honesty, if I were to be a predictor of what the 1 year data will show, I actually think the 1 year data will show a reasonable and comparative mortality compared to what we observed in the old system. But I do suspect that there will be perhaps a slight numerical shift given the intensity of patients. And if you were to look at just the overall, you might actually conclude that there isn't sufficient difference. But I would urge the community to look at the data in a very, very closed way by in fact examining appropriate adjustments of disease severity and the type of patients that actually come in. And in that regard, what will happen, and this is just my prediction, is that you will find subgroups where there is a significant challenge to survival. And we've known this for a long time. If you take ECMO patients and transplant them, their outcomes are not going to be that good. And if your proportionate use of that is higher, then you will see a numerical drop in post-transplant outcomes. On the other hand, if you start gaming and putting balloon pumps in patients and listing them up in the higher priority, they probably will do just wonderfully well post-transplant. And in the aggregate, it might look like there's absolutely no difference to the challenge of survival, but it may very well be that that's not the case. And so I would just urge that even as that data is looked at, that it's looked at with a very critical eye.
Totally agree. And I think that, the famous quote now going around among us is that no one would have ever considered bringing a patient in, putting a swan, and keeping him in the hospital waiting for transplant as a methodology. And now we're starting to say the same thing about temporary support. Next question from Yaz Mwadi. Sorry, Yaz, I know I'm messing it up. Is that if we do believe there's an increased mortality, do we feel that the increased ECMO and temporary MCS are contributing to worsening primary graft dysfunction rates?
Yeah, see, that's Yaz. Thanks for asking that question. And Yaz, of course, has been a incredible thought leader, rising in our field, publishing incredibly important work in this area itself. So I absolutely believe that to be true. I think that first of all, if you ask a very simple question, what is the evidence base for looking at use of temporary mechanical circulatory support devices in patients with cardiogenic shock? I think you will be shocked with the answer because there isn't any. And it's all still based on center-specific, team-based, groupthink type outcomes of which device to use, when should you use them, in what patient, how do you list these patients. So when you have an imperfect decision-making process at the outset, when you don't even know what's the best practice at the outset for support of a patient, you can be pretty sure that that what goes in isn't going to be clean coming out. And I'm absolutely convinced that primary graft failure rates, vasoplegia in particular, that we observe in the early post-transplant phase now, almost a rate of 40% that folks are reporting, is quite significant. And in fact, Shelley, you know the French system very well. You and I were speaking about that just before this conference, and I don't know the details of that, but I do recall having had conversations by our colleagues in France where they moved to a similar type of system at one time point, and they started doing a lot of ECMO-based heart transplants, and they early on they saw a pretty poor outcome in those patients, pretty significant risk of primary graft failure, and then as their practice trends improved over time, they began to pivot, they began to identify the right patient population, et cetera, and outcomes began to improve. I don't know, you probably know more about that, Shelley, since you've critically reviewed that data, and I wonder if you would want to say something about that.
Yeah, thanks. I think it's important for everybody to review the preliminary article is available online. It was sent by the AST weekly email information, and they talk about, it's almost a prediction of what we're going through, and they have created or shifted towards a heart allocation score. Now, before everybody thinks that we just need to replicate what France does, I'd call it a heart allocation score light, because ECMO, it's like out of 1,200 points, ECMO will get 900, a VAD with a complication, or ECMO gets 600, a VAD with a complication will get 900, and then the rest of it is varied by some data. So I think it's, obviously what US is striving to do with the data collection here to develop the heart allocation score to mimic other solid organs. But I think it's a very good read and sort of predicting our debates in the next few years. On that, the heart allocation and the data, Monica Colvin points out here that the new system appears to burden centers with increased data collection, but we need the data to be able to develop scores and evaluate outcomes. How can we improve our compliance as a community with the data collection piece?
It's such a critically important question, right, Shelley? I mean, I think that that the kind of game that we're in for the sake of our patients requires us to be clinicians who also ensure that the highest data quality be looked at, whether it's at single centers or multiple centers or in aggregate. So, Monica, all I would say is too bad. We just have to do it, and we just have to put our minds together. If we don't collect the right critical information and we don't publish in thoughtful ways, then I think we will be doing ourselves and our field and our patients a disservice. And I know you absolutely agree with that. And perhaps the reason you asked this question was for me to emphasize that fact, which is a critical issue for us.
Yeah, I mean, it's absolutely a ton of work for our poor coordinators, and with, shrinking resources, and it does put strain on systems for sure. Another question from Dr. Shanawaz Amdani. After this study, Dr. Mehra, what changes have you made in your center?
Yeah, so what a great question. So it's very interesting. Not all, you could ask a very interesting question, and that is, how do we look at patients? Have we been seeing the same problem with our patients as we have seen in the aggregate data? And the answer is no. We haven't seen that at the Brigham for a variety of reasons. First, we do not directly transplant ECMO patients to a heart transplant. We actually use an intermediate treatment. So what would that be? We typically like to either convert the ECMO patients into a more durable device. We actually have not had very good success using Impella pumps or tandem hearts in these patients, and so we have preferred to use surgical approaches using CenterMag BiVADs in many patients. And whether that is accounting for some of the reasonable outcomes that we are observing at our center, I just simply don't know. But our programmatic approach has been more to rehabilitate patients using a surgically implanted CenterMag strategy, A, because it provides very, very good support to these patients, B, it allows rehabilitation of the patients, and I do admit that it adds cost to the system. I think it clearly pulls on the purse strings a bit more harder than it would in other ways. But we have actually found that we are able to bridge our patients much more successfully to better outcomes.
So in that, how do you reply to the community out there that is worried about, it's sort of this, we're creating this problem, right? We're worried that our durable devices won't get transplanted, so we're trying to get them supported with the temporaries and not move to durable, which just means more donors go to temporaries and our durables get less offers. Yeah. How do we as a community try and fight that behavior?
Yeah. So I think there are two answers to that. So first, I think that we tend to take the direct non-durable VAD to transplant approach mainly in those who need BiVAD support. So these are ECMO patients who can be bridged to CenterMags, or we take bilateral CenterMags. We rarely will have a LVAD CenterMag being bridged to the transplant. Second, our practice, even though our rates of transplants will probably not be the same as other centers, we believe that that transitioning the appropriate patient to a durable VAD without letting them move into extremis is probably the right stance, and we have continued to do that. I can tell you that it strains our discussions at our selection meetings on a pretty regular basis. I think that we are always, our heartstrings are tugged at in a way that is very, very difficult to reconcile at times, where we say, boy, if we actually VAD this patient, then the chance that they will, in fact, get a heart transplant in a reasonable time frame is going to be very difficult. On the other hand, we say to ourselves, what's the benefit if we take 10 such patients and 4 die? or 3 die, I would much rather keep them alive and with a reasonable quality of life with a durable VAD. This is a source of consternation and discussion at our center on a weekly basis every time we're thinking about patients. I personally fight about that. My colleagues fight with me about that all the time. I tend to move towards durable mechanical support personally in the appropriately selected patient, and I try to convince them, and it's difficult at times, Shelley. And I think what this is telling us is that the regulatory aspect, the folks like yourself who are working at the very top of regulatory processes, relooking at potential refinements to this system, ought to help us deal with this situation, because it's just not right for clinicians to not engage in the right therapy for patients at the right time.
I totally agree. In the old system, we simply told a patient, look, there is no way you're going to be able to make it on this device or these drips for 90, 120 days or whatever it might take for you to get to the top and get an offer. So the best chance is to go to an LVAD. And the window has been opened, and it's created these sort of unrealistic expectations. And if we don't change, in my opinion, we're going to end up right back where we were before, which is everybody glutted into the higher systems, and we're back to where we were before. Another question from Jignesh Patel. The mortality curves diverged after 3 months, suggesting that the higher status patients may not have experienced the dreaded PGD. Did this study look into the cause of post-transplant deaths?
Yeah, so of course, right at the top of the hour, we can trust Jig Patel to come up with probably the most difficult question, right, Shelley? I mean, this is the beauty of our group. So thank you, Jig, for asking that tough question. I'll see you at ISHLT and probably have a chat with you then for doing this to me. But no, we did not look at the causes of death. I think the data was just simply not there. But I will tell you that even though PGD occurs early, I think that death in these patients may not occur early, and that we have found ways to temporarily support them through the first 30 to almost 60 days. And very often these patients languish with multisystem organ failure. And it may well be that what we're really observing is infection-related deaths in these patients who then have to be transferred to rehab units. They're deconditioned from all the temporary support going into transplant, and they die of infection, and perhaps we need different ways of immunosuppressing them. But you've asked a critically important question, and I think this is another area where we need to really delve into the data in much more detail and understand the challenges we're experiencing. No question. What a wonderful question, Jake. Thank you for that.
We have a couple minutes. We have several questions. I won't be able to get to them all. I tried to pick ones that hit different topics. So if yours wasn't answered during this time, we will send you an answer in writing. Final question here. What will happen to LVAD patients without complications who are continually bypassed by status 2 patients? Should there be more points allocated for them for LVAD time?
Yeah, so I think there should. What a great question again, right? So I think that first, if I were to give advice to our colleagues in the regulatory process at EUNOS, and Shelley used it on that hill, looking down upon all of us, the 2 things I would say is stop us from the perverse incentives of gaming using less powerful devices like IABPs in some meaningful way. And the second thing is that find a way to not disadvantage left ventricular assist devices in the very egregious way in which this allocation system disadvantages them. To say that an LVAD, the quality of life is exactly the same as say somebody on 0.1 of milrinone, is unwise. And I think that we need to give greater credit for those patients. No question about it. What would you say, Shelley?
I totally agree. I think as we start to analyze and create scores, we're dealing with this with the continuous distribution for lungs. And so kind of seeing the heart future as we watch this process unfold is you're looking at for your disadvantaged patient populations. And durable VADs are going to be disadvantaged in the current allocation. And just like blood type O is disadvantaged right now, and sensitization and other things. And they're going to have to be weight applied to that so that ultimately it doesn't matter your blood type, your size, your etiology, you're all sort of on an even playing field. Now, what that will look like in the future, who knows, but I'm excited to continue to be part of the process. All right, we have reached our hour. As I said, the questions that are still pending, we will get you written answers back to you. I appreciate you're all taking time out of your afternoon to listen. Dr. Mehra, thank you so much for presenting this data, and we will see you all soon at the next meeting, I'm sure.
Thanks so much, Shelley.
Bye-bye.
Thank you, Dr. Mehra, Dr. Hall, and thank you to all of our attendees for joining us today. As Dr. Hall noted, for the questions that we did not have time for, we will either answer them individually offline or we will post the full question with the answer on the website following the Journal Club. Please also remember to complete the evaluation survey and visit myast.org/Journal Club to view our Journal Club archives and register for upcoming Journal Clubs. To learn more about AST's thoracic and critical care community of practice, please visit myast.org/COPS or connect directly via the TCC COP Hub. Thank you all for today's session.